Hello, and thank you for attending today's webinar, How to Position Oscillometry in Respiratory Clinical Research, presented by ERT. Before we begin, we wanted to cover a few housekeeping items. At the bottom of your audience console are multiple widgets, application widgets you can use. If you have any questions during the webcast, you can click on the Q&A widget at the bottom and submit your question. We will try to answer these during the webcast, but if a fuller answer is needed, or if we run out of time, your question will be answered later via email. We do capture all of your questions. If you have any technical difficulty with the ON24 system, please click on the Help widget. It has a question mark icon and covers common technical issues. An on-demand version of the webcast will be available approximately 1 day after the webcast and can be accessed using the same audience link that was sent to you earlier. Our speaker today is Dr. Brian Lipworth of the Scottish Centre for Respiratory Research and 9 Wells Hospital and the University of Dundee. Dr. Philip Lake, ERT Respiratory Specialist, will introduce the webinar and Dr. Lipworth. Phil, let's go ahead and get started.
Yes, thank you very much. So, yes, as Chris mentioned, my name is Dr. Phil Lake. I'm one of the respiratory development specialists at ERT, and we're very excited to bring you this webinar today. So, over the last 20 years or so that I've been involved in respiratory trials, it's always been a challenge to try and see true drug effect, particularly due to kind of technique-based variability. And this is exacerbated in quite a few populations, such as the particularly young or the particularly elderly. So we're very excited for this kind of relatively new approach to a kind of fairly traditional technology, and I'm really looking forward to what Brian presents to actually enlighten us as to how can this be used as we move forward. So over to you, Brian, and thank you very much.
Thanks a lot. So this is the agenda I'm going to talk about over the next 30 or 40 minutes. I'm going to break the topic down into a general introduction in terms of the pathophysiology of airway disease, look at the method of oscillometry as an overview, and then divide it up into asthma and COPD. So without further ado, I'm going to just briefly revise the anatomy of the bronchial tree. Well, as you know, the bronchial tree divides about 23 times from the carina, that's where the trachea bifurcates. Typically, when we're talking about the bronchial tree, and specifically the small airways, these are less than 2 millimeters in caliber, this is from the 8th generation onwards. Anything proximal to the 8th generation from the carina, more than 2 millimeters, is what we call the large airways. Now, how do we assess the small airways? So this is a table from a review which you can read at your leisure in the Lancet Respiratory Medicine, which I published in 2014, which I would commend to you. Of course, we have good old-fashioned spirometry. Now, spirometry measures dynamic lung volumes and forced expiratory flow, and you can ascertain the forced expiratory flow between 25 and 75% of forced vital capacity, the FEF 25-75, and that is thought to represent expiratory-dependent closure of the small airways. But the problem with that technique is it's rather variable, and crucially, it's dependent on volume. So if you don't breathe out all the way from total lung capacity to residual volume, you can get an erroneous result of the FEF 25-75. More sophisticated techniques involves using nitrogen washout, either single or multiple breath, and from that you can get an idea of the variability, or if you like, the heterogeneity of ventilation in these small peripheral airways. But this really is a very specialist technique, and it's not available, I would say, in most offices or clinics. Whole body plethysmography, again, is a rather specialist technique. It's quite expensive, it's very cumbersome. Patients don't like being locked up in a body box for any period of time. And that measures basically trapped gas, so the ratio of residual volume to total lung capacity. What I'm going to talk about is impulse oscillometry, which is a neat new method, relatively new, and this measures both resistance and capacitance. And from that we can derive several outcomes which you can see in this table, and I'm going to elucidate that as we go through the talk. So without further ado, what is impulse oscillometry and how do you do it? Well, oscillometry is actually part of a global technique known as the forced oscillation technique, or FOT. And impulse oscillometry is one of the methods of the forced oscillation technique, to be precise. Impulse oscillometry, or IOS, basically determines the mechanics of the respiratory bronchial tree by superimposing external pressure waves at different frequencies, usually at a multiple of 5 Hertz, and usually between 5 and 35 Hertz, and it's superimposed on spontaneous tidal breathing by the subject. So as such, this is a very physiological maneuver, as opposed to rather artificial forced expiratory maneuver, which is employed in spirometry. And it's very easy for patients to do. If you can breathe, you can do impulse oscillometry. Kids down to the age of 2 and 3 can easily ascertain this technique. So it doesn't require much in the way of any instruction. And also, because it's done at tidal breathing, it doesn't alter the underlying bronchomotor tone. Because when you take a deep breath in, that does modify the vagal bronchomotor tone. What you measure is something called the respiratory impedance. And the respiratory impedance basically comprises 2 components. One component which is what we call in phase, which is the resistance, and another component which is like the ping of resistance, or if you like the out of phase components, which is known as the reactance. So basically, a patient breathes in and out of a mouthpiece, which is attached to a pneumotachograph, which measures pressure and flow, and typically, using the IOS technique, a loudspeaker imparts the sound waves on the bronchial tree. And it takes about 40 seconds to do. So this is the graph which you get out, and on the vertical axis is the impedance, which is either resistance, denoted as R, or reactance, denoted as X, and they have the same values. So what we're looking at here for R or X is basically the pressure-flow relationship. In other words, pressure divided by flow, which is centimetres of water, or kilopascals, divided by flow in litres per second. And that's plotted against the frequency of the sound waves. You've got pressure flow plotted against frequency, and I'll just run you through this. The top line, the solid line, this is the in-phase component of respiratory impedance, the solid line. And that's the resistance, denoted as R. And what you can see is a normal person, there is variability or heterogeneity, which is dependent on frequency of the resistance in the bronchial tree. If you think about this, resistance at lower frequency sound waves travel further and deeper into the lung, whereas higher frequency sound waves travel shorter distances, a bit like radio signals, if you like. So what this means is that the resistance measured at 5 Hertz, or R5, which is abbreviated to, tells you about the resistance throughout the entire bronchial tree. In other words, in the large and the small airways. Whereas the resistance at a higher frequency, at 20 Hertz, or R20, tells you specifically about the resistance in the larger or more central airways. And so, by doing the maths, or as you guys say, doing the math, if you subtract the resistance at 5 Hertz from 20 Hertz, which is known as the R5, R20, that tells you about the resistance in the small airways. Total minus central equals the small airways. If we move on to the interrupted line, this is the reactance. And again, you can see the reactance is also highly dependent on the frequency. So think of the reactance, if you like, as the echo of the resistance, or the out-of-phase component of the respiratory impedance. And again, the reactance, or X, as it's denoted at 5 Hertz, in other words, X5, which is a negative value because it's below the zero line, tells you about the reactance in the small airways. Now, reactance has got 2 components. the negative values of reactance are due to the elastance or the capacitance in the lung, and specifically in the small airways, whereas positive values above the zero line are due to changes in the inertial flow. So really what we're looking at here is the capacitance or elastance or stiffness of the lungs, if you like, call it what you want. And we're looking at negative values. X5 represents the capacitance in the small airways, and we can also measure the area under the curve, which is between 5 Hertz and where it crosses the zero line. And where it crosses the zero line is called the resonant frequency, or FRES. So if you measure the area under the curve, which is shaded there, between 5 Hertz and the resonant frequency, that's known as AX, or the area under the reactance curve, or the reactance area, some people call it. And again, that's very sensitive to changes in small airways. So now you know all about reactance and resistance. So what actually happens in real life? So this is a patient from my own clinic, because every patient that walks through my door gets a measurement of both spirometry and oscillometry. And then we look at both of these readings together. So this is a patient with severe asthma using the tremor flow device, which is a device which I'm going to talk about, which measures oscillometry, a very user-friendly device. And you can see the pre and post bronchodilator traces for this patient before and after inhaling salbutamol 400 micrograms. So you can see there's quite marked changes in both the upper curves, which is resistance, and the lower curves, which is reactance. So to put some numbers on this patient had a 16% change in their FEV1 in response to salbutamol, and a 15% change in response for the FEF 2575, forced mid-expiratory flow. Contrast that, if you will, to a 75% change in the peripheral airway resistance, the R5, R20. So a much better signal, quite clearly here, looking at the small airways in terms of resistance between 5 and 20 Hertz. And if you look at the change in reactance area, the AX, that gives you a 79% change. So you're seeing a much better signal in response to bronchodilator using resistance and reactance with oscillometry than you are with conventional spirometry. So that's the first learning point. Now there's two ways of measuring oscillometry. The first is using impulse oscillometry, known as IOS, and the second is using a more modern technique called airwave oscillometry, or AOS. IOS, which is the older technique, involves using an old-fashioned loudspeaker source, and as such, that involves quite a lot of harmonic distortion. Whereas AOS uses a more modern vibrating mesh source, which involves no harmonic distortion and hence has a much better signal-to-noise ratio. Some other comparisons between AOS and IOS. Well, the most obvious one is you can see on the right that the IOS machine is not portable at all. It's very cumbersome. It's going to take a lot of space in your office. Whereas on the left, you can see the AOS machine, the tremor flow device, is a handheld portable device which you can move from room to room. It's very light and it's very easy for the patient to use. The second big difference is ease of use, and specifically calibration. On the right, you can see my fellow with that big 3.5 litre syringe trying to calibrate the Jaeger master screen IOS device. Takes time. And on the left, a much simpler way to calibrate the AOS tremor flow machine using the calibration device you can see there. The other thing is, if we compare the two devices, the Jaeger master screen and the Thoracis tremor flow, so if we're comparing IOS and AOS, this is a recent study which we've submitted for publication in Lung this year, where we compare the two devices head-to-head in patients with asthma and COPD. And there are some important differences. Firstly, the total airway resistance, or the resistance at R5, was found to be 11% higher with AOS than IOS. So not a big difference, but there is some difference. But the major difference between the two devices is that the reactance area, or the AX, in other words, the small airway capacitance, was 65% higher with AOS than it was with IOS. In other words, it's telling you that with the tremor flow device, the AOS device, that this is more sensitive at picking up changes in small airway capacitance. So I think on that basis, from my perspective, AOS is definitely the way to go. What about oscillometry and asthma severity? So this was a study done with the IOS device, but it could equally be applicable to the AOS device. This was in healthy volunteers, patients with mild to moderate asthma and severe asthma. It was done in our laboratory. And you can see that the first thing to note is that the resistance in the larger airways, or the central airway resistance, R20, does not change as you go from having healthy lungs to mild to moderate asthma or severe asthma. This tells you very clearly that the change in resistance in R5, which you can see, the total air resistance, is clearly being generated by the change in small airways as peripheral airway resistance, or R5, R20. So that's where the action is in asthma. It's not in the large airways, it's in the small airways. And you can see not only that the change in peripheral airway resistance is related to increasing asthma severity, but also the change in peripheral airway reactance, or X5, also changes in proportion to asthma severity. So small airway resistance and small airway reactance are clearly related to asthma severity. What about peripheral airway resistance, R5, R20, in a large cohort looking at the British Thoracic Society guidelines, which are much the same as the GINA guideline steps? So we're looking at steps 2, 3 and 4. What I want you to note here is that even in patients with step 2 mild asthma who've got a preserved FEV1 of 90% predicted, if you look at patients who have abnormal values above the confidence limit for healthy controls, that you can see that over 60% of patients who've got a normal FEV1 will have evidence of peripheral airway resistance. So it's much more sensitive at picking up changes in airway caliber than the FEV1. So small airways dysfunction is actually, as you can see from this graph, is very common across all steps of asthma. This is a more recent paper published 2 weeks ago in the Lancet Respiratory Medicine from the Atlantis study cohort group, looking at the prevalence of small airways dysfunction in asthma. And you can see it's colour-coded in terms of large and small airways. And if you focus on the small airways in green, you can see that measuring the reactance area as AX, or measuring R5, R20, that you're getting a prevalence of around 40% in terms of abnormal values for these measures. So, if I'm sitting in the clinic and I've got a patient with a preserved FEV1, what's the likelihood of that patient having abnormal small airways dysfunction on peripheral airway resistance of R5, R20? And this is a paper that we published from our own group in the European Respiratory Journal. And we found that of 442 patients, 68% of them with mild to moderate asthma had a preserved FEV1. In other words, an FEV1 more than 80% predicted. And actually their mean FEV1 was close to 100% predicted. It was actually 97% predicted. And in these patients who had a preserved FEV1 with a mean value of 97% predicted, 45% actually had an abnormal oscillometry value of R5, R20 more than 0.07 kilopascals per litre per second. So you can see again that it's very useful for picking up small airways dysfunction in patients who have preserved spirometry. Now what we then went on to do in these patients, and you can see that these were patients 302 patients with a mean FEV1 of 97%. Their mean inhaled steroid dose was 800 micrograms a day, and nearly half of them were also taking a long-acting beta agonist. So this was a health informatics study that we did in Dundee, looking at follow-up of control over a 2-year period. So it is a long-term study. And what we looked at from prescription event monitoring was the use of oral corticosteroids and short-acting beta agonists. And what we found was that in patients who had both a raised peripheral airway resistance, R5, R20, and a low FEF 25-75, that they had a high burden of poor disease control. In other words, their oral steroid use was 57% higher, and their albuterol use was 68% higher in these patients who had small airways dysfunction. So the conclusion of that study was quite clearly that we should really be using spirometry in conjunction with oscillometry to correctly and accurately stratify the risk of impaired asthma control, and that's exactly what I do in my own clinic for every patient that walks through the door. Well, if you're still not convinced, check out these data. Again, this is another study from our group that we've published in Journal of Allergy Clinical Immunology. So these were more severe asthmatics, where we looked at their asthma control questionnaire score. So a score more than the 1.5 threshold means that they've got poor asthma control. And here presented are the means and the 95% confidence intervals for the ACQ-5 score. So you can see these patients were poorly controlled. On the left of the interrupted line, you can see that the ACQ score was significantly higher in patients who had a higher R5, R20 value and who had a higher AX value. In other words, these patients who had high peripheral airway resistance and who also had high airway reactants, their ACQ scores were significantly worse. But when you look at the same patients broken down according to spirometry, whether that be an FEV1 or an FEF 25-75 cutoff, we didn't see the same difference in ACQ-5. So clearly this is telling you, in relation to asthma control measured with the ACQ score, that impulse oscillometry is more sensitive than measuring spirometry. This is looking at two formulations of long-acting beta agonists, namely a small particle formulation of formoterol and a large particle formulation of salmeterol, looking again on oscillometry. So this was looking at chronic dosing at steady state, comparing the small particle formoterol with the larger particle salmeterol. And you can see quite clearly that using impulse oscillometry as R5, R20, reactance at 5 Hz, or the reactance area AX, that it clearly delineates a difference in bronchodilator response between the small particle beta agonist and the large particle beta agonist. And these changes were not evident on FEV1. So again, if you're looking at response to a bronchodilator drug like a long-acting beta agonist, you're going to get a much better readout in terms of sensitivity using impulse oscillometry. That was the conclusion of this study. And you see the same thing with inhaled steroids. So here we've got a comparison head-to-head over 3 months of large particle CFC beclomethasone and small particle HFA beclomethasone, looking at peripheral airway resistance R5, R20. And as you can see, over the 3-month period, whilst the peripheral airway resistance fell in response to the small particle inhaled steroid, it didn't significantly change with the large particle inhaled steroid. So again, showing clearly that measuring small airway resistance using oscillometry will detect better a response to inhaled steroid in the peripheral lung. So let's just summarize this up. Small airway dysfunction, as you've seen, is common across all asthma severities. Small airway dysfunction is clearly related to poor asthma control. Resistance and compliance are concordant in asthma. In other words, when one is abnormal, the other will also be abnormal to much the same degree. That's what I mean by concordant. And R5, R20 and AX are the most sensitive markers of small airways treatment response. So let's move on to COPD now. We've covered asthma. And this is, I would say, a typical phenotype, small airway phenotype of a patient with COPD. Because all patients with COPD have a degree of small airway disease. So a patient on plethysmography will have a high total lung capacity due to hyperinflation. They'll have gas trapping in terms of a high residual volume or a reduced forced vital capacity measured on spirometry. They'll have a high peripheral area resistance. They'll have a high reactance area and a low reactance at 5 Hertz. And if you do nitrogen washouts, you'll notice that there is evidence of ventilation heterogeneity. And if you do a high-resolution CT scan, they'll have a higher proportion of low attenuation area. That's a typical phenotype, if you like. So what actually happens in real life? So this is a patient that came to our research group, a heavy smoker, as you can see. This was a patient who didn't have asthma. You can tell that because their exhaled breath nitric oxide is normal, as is their peripheral blood eosinophil count. And so we did a standard 400 microgram albuterol reversibility. And you can see the values here, pre and post salbutamol. And this is one of the problems with spirometry, because if you do the best of 3 values, you get progressive worsening in dynamic lung volumes. And you can see that rather than showing reversibility, this patient actually got worse when they inhaled salbutamol. That's nothing to do with the drug. The beta agonist does what it says on the tin, it bronchodilates. But it's the procedure, the forced expiratory procedure, makes these values progressively worse. And this is something that we often see in clinic. And that's one of the limitations of using spirometry in clinical trials with COPD. Now note that while the patient's FEV1 and FVC got worse with salbutamol, that their total area resistance and their reactance area got significantly better. And on that basis, we knew the patient would get better if we put them on a bronchodilator drug, which we did, and they came back and they were dramatically improved. So, are there any data from larger cohorts? This is the Eclipse cohort. This is the GSK Eclipse study in large numbers using impulse oscillometry across gold stages 2, 3 and 4. And what I want you to note here is that the peripheral area resistance, the R5, R20, does increase from gold stage 2, 3 to 4, but the increase in peripheral area resistance with increasing COPD severity is 60%. If you look at the reactance area, in other words the lung stiffness or the compliance of the lung from gold 2, 3 and 4, then the difference is twice as great. It's 136% difference in AX reactance area plays a 60% difference in R5, R20. So here you're seeing now emerging a pattern that measuring lung compliance or lung stiffness with the reactance area is clearly more sensitive to COPD severity than measuring R5, R20. In other words, there's relative discordance. Reactance is more sensitive than resistance in COPD. That's the learning point. And here's another study looking at patients in terms of their exacerbation frequency over the past 12 months. And again, you see exactly the same pattern. Comparing gold stage 4 to gold stage 1, you're seeing only a 39% difference in resistance at 5 Hertz, total area resistance, whereas if you look at reactance area, you're seeing a 238% difference. So clearly, again, this reiterates the point that in COPD, it's reactance or lung capacitance which is more sensitive to changes in disease severity than resistance. This is looking at artificially induced bronchoconstriction with methacholine bronchial challenge in patients with COPD. So as expected, The FEV1 falls because this was a challenge to induce a 20% fall, a PC20 in FEV1. But I want you to note that whilst the FEV1 fell, the resistance at 5 Hz did not significantly change, but the reactance at 5 Hz did significantly change. So again, we're seeing a discordance between changes in resistance and reactance in COPD in response to a bronchoconstrictor stimulus. In asthma, whilst the FEV1 fell, we saw a concordant change in both resistance and reactance, in contrast to COPD, whereas only the reactance changes in COPD. In asthma, as you saw previously, resistance closely follows reactance. And this is a study that we did in patients with COPD, where we looked at them at baseline, and then we gave them an inhaled steroid LAVA combination, which was beclomethasone formoterol, and we gave it them with a non-selective beta blocker to induce bronchoconstriction. And the beta blocker we gave was carvedilol. So you can see that after giving carvedilol, even in the presence of inhaled corticosteroid and long-acting beta agonist, as you'd expect, the patient's bronchoconstricted. So there was a small fall in FEV1. There was no change in resistance at 20 Hz, which is central airway resistance. So you can see here that central airway resistance is not where it's at in COPD, not the large airways, they don't matter. But if you look at the smaller airways in terms of R5, or in terms of the X5, the reactance, or the reactance area, you can see now that you're getting a much bigger signal in response to beta blocker-induced bronchoconstriction. And actually, it's very clear that the biggest signal, the greatest sensitivity, was seen with the reactance area. Then what we did is we continued with the carvedilol, but we stopped the long-acting beta agonist. So what happens when you remove the beta agonist? Well, you can see the AX shoots up even further. The FEV1 doesn't really change, the R5 doesn't really change, and the X5 doesn't really change. And that's why I think that measuring the reactance area, looking at the small airway capacitance, is really the most sensitive outcome for drug trials in COPD. If you're still not convinced, check out these data. So this is data in COPD in patients who were given tiotropium alone, or given tiotropium with a long-acting beta agonist called tolbuterol. First thing I want you to note on the top right, graph B, is that the central airway resistance in the large airways doesn't change whichever bronchodilator. So as I said, it's really the small airways which matter in terms of determining treatment response in COPD, not the larger airways. And if you look at the total airway resistance, that changes, it falls in response to either tiotropium alone and falls further in response to the long-acting beta agonist, and it's the same pattern with the reactance area. And you can see clearly that the greatest magnitude of change in response to tiotropium or tiotropium with tolbuterol is actually evident with the reactance area. So if we're comparing spirometry and impulse oscillometry in COPD, these are the outputs which you get. You know, FEV1, FVC, FEF25, 75 with spirometry, and the oscillometry outputs are R5, R20, X5, AX, and the resonant frequency. The signal-to-noise ratio is pretty good with both, but as you can see from the previous slides, it's better with oscillometry than it is with spirometry. In my opinion, oscillometry is much more patient-friendly than doing spirometry because it avoids doing the forced expiratory maneuver. It's done with normal physiological quiet tidal breathing. The only big difference, I would say, the only downside of impulse oscillometry is that there aren't the same standardized reference values for COPD with oscillometry compared to spirometry. But the big difference with oscillometry is it allows you to differentiate between the small and large airways, which you really can't do with spirometry. Cost-wise, well, a spirometer is going to cost you much less than an oscillometry machine. Portability-wise, certainly with a tremor flow device, the airways oscillometer, the tremor flow device, is equally as portable as any spirometer, and both of these are now FDA approved. So to summarise the use of oscillometry in COPD, lung compliance is more closely related to disease severity than resistance. That's very clear. We don't really know, though, whether lung compliance or reactance is predictive of exacerbations because there have been no longitudinal studies. My guess is that it would be highly predictive. The large airways, measured as R20, they're not involved in differentiating COPD disease severity, and they're not involved in determining the response to beta agonists or muscarinic antagonists. As you've seen in COPD, resistance and compliance are relatively discordant in COPD, whereas they're more concordant in asthma. And lung stiffness, as AX, is more sensitive than resistance in terms of measuring bronchoconstriction or measuring bronchodilation. So why should we use oscillometry in clinical trials? Well, the first point is, just to reiterate, is it's more physiological than spirometry because it's performed with quiet tidal breathing. Secondly, it's much easier for patients to perform than spirometry. Thirdly, it provides very important information on regional lung function in terms of resistance and compliance in asthma and COPD, and you don't get that from spirometry. The new airwave oscillometry device, the AOS Thoracis Tremor Flow device, is more sensitive, it's portable, it's more user and patient friendly, and it's actually more cost efficient than the old school IOS device. And that's the way forward. I look at it that the new Tremor Flow AOS device, it's like the sort of iPad of oscillometry devices, whereas the old IOS device is like a big old cumbersome desktop. So oscillometry, I think, should be used in conjunction with spirometry in any clinical trial to comprehensively assess patients with asthma and COPD. And that's what we do in all of our clinical trials now. We would never do one without the other. After this, I'll now hand over for any questions. Thank you for paying attention today.
Thank you for a great presentation, Dr. Lipworth. We really appreciate it. Phil Lake's going to come on as well. I believe we have a number of questions from the audience and some really good questions. Phil, you want to get started?
Yes, I will. So, thank you again for that great presentation. So there's a number of questions that have come in, so I'll work through them. I mean, you clearly show that there's a great potential for this technique. But how far do you think we are from the regulators accepting AOS data for a kind of primary label claim? Will it always just be supporting kind of traditional spirometry, or what do you think?
Well, the FDA are pretty stuck in the mud and very tricky. If there's anyone listening from the FDA, I make no apologies, but it takes a lot to shift the FDA in terms of anything. In terms of using AOS or IOS as a primary endpoint, I don't personally see an issue with that because I think there's a very compelling case. In terms of persuading the FDA for that, that's a different kettle of fish altogether. But it would certainly be very good, I think, to use AOS as a supportive measure if you've got, for example, non-significant trends in spirometry. So you might have a study where you've got a non-significant trend in spirometry but a clear significant trend in AOS, and I think that would then compel the FDA to allow you to go on to do a further study powered on AOS. I think that's the most likely scenario, in my humble opinion.
Okay, that sounds good. And then one which relates really to how sensitive AOS is for picking up kind of symptom-based changes or kind of quality of life changes, such as, I think you showed some data for ACQ, but things like SGRQ or AQLQ. Any thoughts on that? Yeah.
Well, to be honest with you, SGRQ and AQLQ are very insensitive in COPD and asthma, respectively. And I actually can't, I'm pretty close to the literature, trust me on that. And I actually can't think of any study that was powered on SGRQ or AQLQ in COPD or asthma, respectively, that managed to pull out. So the question is this predictive of health status or quality of life? I don't know, because no studies have actually looked at that specifically, but it's certainly something worth studying. But to be honest with you, my opinion is I'm not very impressed with these health status or quality of life measures anyway. And it'd be very difficult to power a study on either of these in patients with COPD or asthma.
Yeah, no, I think I probably agree with you there. So there's a couple of questions about the reference values and potential for the reference values. So, I mean, is there an organisation that's starting to collate these, or do you see that we're going to get reference values in the near future?
That's a good question. The Atlanta study group, I think I showed you a slide from the Atlanta study group published in Lancet Respiratory Medicine, will almost certainly be coming out with reference values for patients with asthma and COPD. That's part of their remit. So that's something which is coming in the pipeline.
Okay, thank you for that. Now, there's another question was, so it's quite clear that this picks up some kind of patients with preserved FEV1, and then the treatment effects are larger. So based on that, do you see that there's a correlation there that you can start to show accurate treatment effects with smaller numbers of patients?
Yeah, you've hit it on the head. I mean, when we're powering studies using EOS, you need much smaller sample size than you do with studies powered on FEV1. So the answer to that is a simple yes. Okay,
sounds good. And I had another question here about if you were to see well, I'll read it out verbatim. So would you worry about the quality of post-bronchodilator tests if the R5 changes?
I don't quite understand where you're coming from there.
I'm guessing whether there was a significant increase in the larger airways versus the smaller airways. I'm not entirely certain.
Sorry. Are you saying that if there was a large? I'm guessing actually you mean the opposite. You mean if there was a large change in R20? And that doesn't bother me. What you're really looking for is the heterogeneity of frequency-dependent resistance. So yeah, if the R20 goes up by 15%. That doesn't really matter. It's the difference between R5 and R20 that matters. So you might get, for example, a 60% in change in R5 and only a 10% change in R20. But it's the difference between the two. In other words, the frequency-dependent heterogeneity, which is what matters.
Right. I think that's answered it. So if that's not clear for the questioner, just write back in and we'll have another go. So another one here about the potential for using EOS in diseases like pulmonary fibrosis.
Yeah, there's really very little data, and that, to be honest, that's outside of the scope of this presentation. But in theory, I know where you're coming from here, because measuring reactants, not resistance, is useless in pulmonary fibrosis. But if you're looking at reactants, particularly X5 and probably more so AX, I suspect that would be a very sensitive marker of trials, for example, in IPF. But that's not been looked at prospectively. But my guess is that it would probably be more sensitive than measuring forced vital capacity, which is currently considered to be the gold standard for IPF studies.
Excellent. Thank you very much. I'm just looking through to see if we've got any further questions coming through. I think we've broadly covered them all.
Okay.
So again, if there is any additional questions from anyone in the audience, if we've not got through them in here, we'll run through them again, or send them through, and we can follow up via email.
Yeah, that's great. And we did confirm that one question was on, I believe, R20. So we're good there. Phil, before we end, could you tell us a little bit about ERT's solution for oscillometry and how that works in clinical trials?
Yes, by all means. So I think Brian mentioned a little while back that he's been using the Thoracis device. So for within ERT, we're actually using the same device, and we have that integrated into our Masterscope platform. which kind of drives a lot of the other functionality in terms of spirometry and pheno, for example. So the core benefit in this respect is that this all runs through a similar platform, and you can actually kind of help the site run through the core protocol with all the assessments in the right order by running them through that. So this is the core approach from the ERT side. Now, again, we have the kind of potential here to review this data and then to feed back to sites if there's any potential issues there. Now, all of this will help to kind of reduce variability and should give you a much clearer determination of treatment effect. But I don't actually see the slide at the moment. Chris, is there another slide here? Let me just go to this one. Right, excellent, got it. So I can see the slide now, so that's great. So in relation to this, I mean, you can see here the core respiratory kind of slide for ERT. So this technique really sits very nicely with the whole philosophy that we run through. So our main goal really is to, as I mentioned before, is to reduce variability so you have a much clearer indication of the true treatment effect. So this is both to try and strip out some of those problems that we see in traditional spirometry, but we run through this in all of the core areas we look at. The other element about the kind of ERT platforms and systems are they're really designed to try and make things as easy as possible for the site. So again, to actually highlight issues when they occur and to actually make it easier for them to drive better quality primary data. So this really is the holy grail for us. So if you can actually see issues and understand that you've got good quality data while the patient's sitting there in front of you, you can do something about it, and you don't end up retrospectively finding out that the data is corrupted whilst it's already in your ITT population.
Thanks, Phil. We'd like to...
Broadly, yep. Carry on.
If you have anything else, go ahead, Phil. That's all good.
No, that's me.
Okay, great.
Thank you.
Well, I think it was a great presentation, and I certainly learned a few things today. So we'd like to thank everybody for attending today's webinar. This webcast will be posted for on-demand access in the next 24 hours, and you can always email events@ert.com to request a copy of the presentation deck or for any further questions or answers. Stay tuned on ERT.com for upcoming webinars, podcasts, and other useful content on clinical trial safety and efficacy endpoints, as well as data integration analytics and real-world evidence to help you minimize risk and move forward quickly and with confidence in your development programs. This will conclude our webinar for today, and we hope that you have a great day. And thank you so much for attending.
Thank you very much.